So I've changed the scope of my presentation just slightly where the focus is actually going to be on leveraging databases or large healthcare utilization databases to assess trends in use of antiretroviral therapies in pregnancy, with the hope of using these data to add to the evidence generated on the safety of these medications to have more precise estimates. As you could tell from Kelly's presentation, is that a lot of the evidence that is generated seems to suggest that these medications are safe, but the estimates are quite imprecise. And before I begin, I just want to acknowledge my mentors and collaborators on this project, as well as various funding sources. About a quarter of the million of people living in the US with HIV are women, and between 6,000 to 7,000 of those women living with HIV give birth each year. And I just want to pause here and say that in order to be consistent with the statistics and literature already published, I am using the term women when really I want to refer to birthing people and acknowledging that not all birthing people are women. But one of the major public health successes has been in the reduction of perinatal transmission of HIV, which is about less than 1% in the US. And for people living with HIV, as Kelly's presentation mentioned, there's a standard treatment using antiretroviral therapies, which include different classes of drugs based on different medications to inhibit the replication of these retroviruses. And the initial treatment generally includes about 3 medicines or so from at least 2 different drug classes. And for pregnant people, the current guidelines are to continue their current course of treatment unless one of the medications or more in their regimen is not recommended during pregnancy, or for pregnant people who are identified as having HIV during their pregnancy and who are treatment naive, to initiate treatment as soon as possible. And given this, prospective tracking of in utero exposure to these antiretrovirals is critical so we can evaluate the safety of these medications with respect to fetal development, especially as newer medications and newer formulations are introduced. Most of the evidence for medication safety in pregnancy is generated post-marketing, and there are a few different surveillance strategies that are available to us to generate epidemiologic evidence of medication safety. And for the sake of this presentation, I'll focus on 2 exposure pregnancy registries, being the first one. And here I have a copy of a guidance documentation from the Federal Drug Administration talking about leveraging registries to support regulatory decision-making around medications and biologic products. And specifically for antiretrovirals, we have the Antiretroviral Pregnancy Registry that I'll refer to as APR for the remainder of this presentation, which is an observational exposure registration prospective follow-up study, and annually enrolls about 1,000 pregnant people exposed to ARTs for either the treatment of HIV, the treatment of hepatitis B, as well as people who are exposed to ARTs for pre and post-exposure prophylaxis. And it's surveillance. The goal of APR is surveillance of major teratogenic effects of these ARTs from all reporting countries. So about 3/4 of the pregnant people enrolled in APR are from the US, and the last quarter from various countries that report to this registry. And surveillance has been ongoing since 1989. Some of the advantages of the registry is having prospective drug information, having longitudinal information in order to estimate risk and risk differences, as well as it's efficient, right? Focusing on a select number of medications really allows for an efficiency when it comes to being able to generate evidence for these medications. They're also able to assess real use through interviews and having information from healthcare providers who are submitting data to these registry on clinical indicators, as well as having information on sociodemographic characteristics directly from the people who are on these medications. But the registry is not without limitation, so we can talk about left truncation. So if the enrollment of the pregnancy happens later in the pregnancy, as well as having under or differential reporting of exposures, and the same can be said for outcomes in the monitoring of these congenital malformations, not having a comparable external comparison group, as well as the data collection happens ad hoc, and so it can be timely and costly for the healthcare providers that are providing the data to these registry, as well as having loss to follow up. And so this is where healthcare databases can come in, having these like large utilization healthcare databases in terms of trying to modernize post-marketing surveillance research. There's been an increased interest in these large database studies, and you can see from the picture on the right where you see an almost doubling of database studies from 2012 to 2018 compared to the previous time period of 2005 to 2011. And even further, there's sort of a paired request, so having information from both pregnancy registries and database studies have become more common, and also thinking about it in the wake of a 2016 legislation called 21st Century Cures, thinking about the marriage of speed and ease versus science, so really leveraging real world evidence in order to contribute to post-marketing safety evidence. And this is just a graph showing the exponential number of publications that are interested in drug safety and pregnancy that have been using healthcare utilization data. And you can really see how much use of these healthcare utilization data has grown in the last 10 years. So looking at this 2010 to 2020 period, but really starts in the early 2000s. And so with that, we were really interested in looking at comparing the antiretroviral pregnancy registry. They have an interim report that includes pregnancy enrolled. So the current report includes pregnancies up until the case closed for the 31st of January 2024. So we assume that these are pregnancies up till the end of 2023. And we compare that to a pregnancy cohort that we have nested in the Medicaid Analytic Extract Transform Statistical Information System analytic files. Try saying that 3 times fast. And for the presentation, I will just be referring to this as MAX. And for MAX, we have data from 2008 or we focus on data from 2008 to 2018. MAX is a cohort that includes publicly insured individuals from 12 to 55 years. We also link our data to the infants, as well as requiring them to have a live birth delivery. Also, another requirement was having continuous insurance coverage for 3 months before the date of the last menstrual period to 1 month after delivery. And in order to identify people living with HIV, we used a validated algorithm with these 3 criteria where a person would be identified as having HIV or living with HIV if they met 1 or more of these criteria. So either having greater than 2 diagnostic ICD codes separated by at least 30 days, or having a diagnostic code and 1 HIV-related procedure, or having a diagnostic code and greater than 2 dispensations for antiretroviral therapies. And then in terms of the exposure, we considered people as having ARTs during pregnancy if they had greater than 1 dispensation for an ART from about 3 months before their last menstrual period to 3 days before delivery. And although I don't present the results here, we also looked at ART during labor, which is in the period of 3 days before delivery to delivery. So we did some descriptive analyses looking at the overall prevalence of pregnant individuals meeting the definition of HIV in these data. So in the MAX cohort, the percentage of people living with HIV with an ART dispensation, as well as different demographic characteristics. And this is where things get interesting, right? So at first we look at the HIV prevalence, and it's about 0.3% in these data, where greater than 60% of the people are younger than 30 years old. And then we also have this racial and ethnic distribution, where we see that the majority of pregnant individuals in these data who are living with HIV are Black, and also noting that nearly 80% of them have a diagnosis for HIV, so have a claim that is consistent with our algorithm for HIV diagnosis before the pregnancy is identified, or at least within the first trimester. But then we see these really surprising numbers where about 35% of people in the database are identified as living with HIV, but have no ART dispensation. And then what's even more surprising is that about 66% of those with no ART dispensation have a claim indicative of HIV infection either between last menstrual period and the end of the first trimester. So these are people that have a claim indicative of HIV infection pretty early in their pregnancy. And then another surprising thing was that about 48% of these untreated, and I have untreated here in quotation marks, because spoiler alert, I don't believe this 35% number, are in the Northeast and 90% in the South. And the reason why this is also surprising is that if you're familiar with HIV data in the US, we actually see a disproportionate number of people living with HIV in the South. And so we wouldn't expect that nearly 50% of people who are living with HIV not on ARTs are living in the Northeast. And given that I talk about the fact that perinatal transmission has decreased to less than 1%, I think if 35% of people living with HIV weren't getting treatment, we would see perinatal transmission being a lot higher. And so initially I was like, oh, is this a ring the alarm situation? And I think it's not, but rather perhaps a misclassification problem in the use of these data. So either our algorithm is identifying people as having HIV who do not, and so are we capturing people who perhaps have codes for HIV tests or procedures but don't actually have HIV, or given that like this is a validated algorithm, these people might actually have an HIV diagnosis and have treatment, but for some reason are not being captured as being on treatment in these data. The other thing that we're interested in terms of being able to leverage these databases to generate evidence of safety is also thinking about the accumulation of exposed pregnancies in the databases compared to the registries. So one of the limitations of registries can be small sample sizes, although as I mentioned, APR enrolls about 1,000 pregnancies per year. And so here we looked at cumulative exposed pregnancies to a particular medication in the databases and tried to extrapolate to sort of the same timeline compared to registry, given that the registry has more data available than the database. And I looked at a newer medication for comparison, so looking at dolutegravir, which was approved for medical use in the US in 2013. And if you can see here, the database is lagging quite behind when it compared to the registry. So these are data that look at dolutegravir in the first trimester, because that would be the etiologic period relevant for congenital malformations for the most part. And we have data for dolutegravir starting in 2014, given that it was approved for use in 2013 in MAX up to 2018. And if you look at 2018, so cumulatively, we have less than 250 pregnancies exposed to dolutegravir in the first trimester. As opposed to in the registry, there's a little under 1,200 by the end of 2023. And so the registry is outpacing the information available on pregnancies exposed to dolutegravir in the first trimester than the databases. And then from Kelly's presentation, you'll remember interest in these newer ARTs. So we also looked at the accumulation of newer ARTs, and consistent with Kelly's presentation, we do see darunavir as being the medication that we have the most pregnancies exposed to, and we expect to not have as many pregnancies. So we have one pregnancy exposed to bictegravir, which currently is not recommended for use in pregnancy. So we do have some sample in order to be able to generate evidence of these newer ARTs. But again, uptake is a lot slower than we would anticipate compared to the registries. And so these are some of the questions that I have for this work in progress, is thinking about validity and misclassification. And so, as I'd mentioned, having these people with HIV diagnosis and no ART dispensation, are they false positives? I'm not sure that I believe that they're false positives, but I think that for some reason, we're just not capturing their treatment status. And then there are about 100 people or so who have ART dispensations, but have no codes for HIV diagnosis. And so do we believe that these people are people who are on ARTs for either pre or post-exposure prophylaxis, or are they false negatives where they actually are living with HIV, but for some reason their codes have not been captured? And then also thinking about this timing issue in terms of accumulation of data in order to be able to have enough exposed pregnancies to these medications to look at these questions of medication safety, contribute to the evidence, and especially given that we're interested in first trimester exposures for congenital anomalies. And then to try to look at this misclassification issue, we've reviewed claims profiles for a random sample of people with HIV diagnosis and no treatment. And what I've noted is that they have many interactions with the healthcare system. They do have codes specifically for HIV disease, so not just for testing. And so these are people who do have a claim for an HIV diagnosis and have claims for different medications, but don't have claims for ARTs. And so it's still really hard to believe that people who have all of these interactions with the healthcare system, who have a diagnosis, would not be on treatment. And so perhaps currently the data in the registry are better suited for generating epidemiologic evidence regarding ARTs, or perhaps what we can say is we can focus on commenting on trends, but can't really comment on this untreated population, given that there are potentially denominator issues with our data. I want to say thank you, and I'm open to any questions or suggestions as we work through these methodological challenges as we think about use of healthcare databases and big data to generate evidence for medication safety.